Good evening, everyone, and welcome to today's session titled How Nutrition Can Best Support Mental and Physical Health. My name is Dr. Reem Badawi. I'm a child psychiatrist at Mosley Health Abu Dhabi, and I would like to introduce our first speaker, who is Jean Bedard in the UAE. She's the head of dietetics at Perfect Balance, which is on Reem Island. She's a graduate from McGill University, licensed by the Health Authority here in Abu Dhabi, and is a member of the Dietitians of Canada and Quebec. Her 12 years experience in providing nutritional services in outpatient, inpatient home care and virtual healthcare settings has spread over the Middle East, Central America, and Canada. She is also a co-author of a book on nutrition and mental health to be published by Montreal University Press in 2020. And she has also developed and launched a food guide endorsed by the Ministry of Public Health of Haiti, with a strong emphasis on empowerment and nutrition and nutritive value of local foods. Jean has been delivering conferences for various communities and groups, ranging from local family cooperatives to the United Nations Food and Agriculture Organization. She promotes personalized nutrition and addresses the physical and psychological health and well-being.
Good morning, everybody. I think you're going to be watching this in the morning. I am recording this from my home in Abu Dhabi. I hope everybody is well. It is a pleasure to me to present today a few concept strategies, research, and also my clinical experience about how nutrition can best support mental and physical health. I am a clinical dietitian at Perfect Balance on Reem Island in Abu Dhabi. I have also worked in the Mental Health Research Institute in Montreal. Mental health is really dear to my heart, and as I will talk about today, I do think that we can do better when we talk about nutrition to support it. Oops, here we go. So the first thing that I would maybe start by linking is the way that we talk about nutrition and physical health. And in a lot of ways, I think it's being talked about more and more in our field, is about how the nutrition and physical health are linked in a very weight-centric approach. I have the pleasure of having Dr. Karine speaking after me today about weight stigma. So I'm not necessarily going to talk a lot about that today, but I want to kind of make that connection because it's something that I think is very important when it comes to nutrition and physical health and mental health together. Sometimes I give a little bit of the analogy of focusing mostly on weight when somebody walks into a doctor's office or with any health professional really, or in their day-to-day with their family and friends. They're often, people will comment on their weight, people will be quoted their BMI, would be recommended to lose weight, and given some broad recommendation about moving more, eating less, and so on. And I think you would agree with me if you read any of the research regarding weight stigma that can have negative health impact for people. So the analogy that I was coming to was when people walk in my office and focus mostly on I want to lose weight, I tend to say that it's kind of the same as playing your favorite sport. Here I have like the football, and if you were playing a football match or soccer for anybody from Canada, if you were in America, if you were playing a football match and the entire game you're just looking at the score, and very, very like centered on those numbers, you would play a really, really bad game. And that's often how I introduce the link between the weight, nutrition, and physical health. It's not that the score doesn't exist, but if you were to watch a football game and this screen would be on all the game, you would probably get really bored of watching it really quickly. So context of nutrition, physical health, and then we move on to the context of nutrition and mental health, which in a lot of way I find is presented in a very simplistic way, where if you eat well, you're going to feel great. You need to nourish your brain. You'll see very dichotomic images of, great food for the brain and things that would be detrimental. And I don't think, unless I see or I listen to some talks today that will be revolutionary, of course, in the context of nutrition consultation, I would move towards and promote having adequate amount of omega-3, vitamin D, folate, which early research can link to improvement of mental health. So of course, nourishing and nutrient density can support global health. But as we're going to see in another presentation today about the determinant of health, we need to look at a bigger picture. There's just so much more when it comes to nutrition and mental health. And today what I want to talk about is a little bit of that spectrum of, I do see people with eating disorders, anemia, anorexia, but I also see people that are kind of the middle of the spectrum, whether it is from a physical health standpoint or a mental health diagnosis standpoint. You see people that are coping or struggling with different contexts around food, around their body, around weight. And that's where I think we can do better, because regardless if they have a diagnosis, a mental health diagnosis or a physical health diagnosis, often there's a lot of information overload. I think you would agree with me that in the health field, in the nutrition field, whether it is in social media or in research, there's so much out there. There's so much information, and even more so maybe in the UAE, because there's such a diverse community. People are different, they have different food culture, and so there's so much that we can grab from outside. And this information overload is real, not necessarily always conducive to optimal mental health. One of the major points that those information that we can gather from different places is about what to eat and how much to eat. And I get the sense sometimes when I talk to other health professionals that's what people think that dietitians do. We tell people what to eat and how much to eat, and we send them on their way. Now, although it is the reality, and it is in a lot of ways how we were trained and still being trained, I think there are different ways of talking about food that better support mental health, because at the end of the day, we are all in the healthcare system to help and to do no harm. And I want to give you some example of 5 things that I would keep in mind, and I hope you would keep in mind in your conversation with your family members, with the conversation with your patients, regardless of your field or your specialty, and maybe also consider when you refer out to a dietitian. The first one would be about expertise and collaboration, and I talk about collaborative care in the sense of we need to address people's motivation, and also I talked about weight stigma, but some feeling of guilt and shame around their body and food. One way to do that is through motivational interviewing, which can be used and has been researched in so many different contexts, not just in the context of food, of course. I know because it's a mental health conference, probably a lot of you are knowledgeable already about motivational interview. I do think that we can bring that into nutrition a lot more than it already is. And basically, for those who are maybe less familiar with motivational interviewing, there's a few principles of partnership, acceptance, compassion, and evocation that are at the central of the care. And when we talk about nutrition, that would really have an impact on how we ask open-ended questions, how we reflect, how we let the person maybe talk a lot more than we're actually going to do. So it's less about recommended what to eat and how much to eat, and a lot more about listening to what they have to say about their motivation, try to reflect on what's their pros and cons about making certain changes, and also the concept, what I call not insulting people's intelligence. And I talk about that. It's very dear to my heart because, let's be honest, nobody that you will tell their BMI or that they need to eat more vegetable will be totally odd and be like, oh, wow, I've never heard that. So I find that motivational interview for me is a way of moving people, and in research as well, is a way to moving people from knowledge to action, to accompany change, build confidence, clarify why certain things are important for people to change, and then move from there to very much take the information overload, maybe distill all of that, explore with the patient what is most important for them, and then move to action. The other part that is increasingly important when we talk about mental health diagnosis is that we know that in the context of psychotic disorder, for example, the executive function can decrease. And so executive function, I think in terms of nutrition, I talk about meal logistic versus meal planning, and how do we help people, again, move from the knowledge that they have to actually taking action and having a process that is clear and defined to make those changes. So maybe I can give you a few more practical examples about what I talk about when I talk about executive function is beyond telling people what to do, would be to address, okay, when you eat food or when you plan for food or cook meal for your family, what are the default settings? So what I would do with people would do a go-to meals list of, I know that you might want to eat a certain way, you might have a lot of knowledge, but in real life, what are the main meals that you eat more often? And then from that already, I would say, acquire knowledge of how to prepare those meals, then we would build and improve on nutrient density. We would probably maybe help into saving time in the preparation, giving people inspiration from what they already know or like. So it could be a variation of what they already know. Maybe it sounds funny in certain ways, but in a lot of ways, addressing grocery shopping and how the meals that we are planning or we want to try or that we want to improve the nutrition value of needs to be linked to the grocery shopping, needs to be linked with what is available. On the other end, at the same time in the UAE, a lot of people might have somebody that is helping in the kitchen, maybe elsewhere in the world, but in terms of cooks or nannies or helpers that would make the food. And you need to talk to those people in a different way than you would talk to people that would cook all their meals, right? So it's beyond telling people what to eat. Sometimes it's a gap in the communication. Sometimes it's a gap into making food available to cook the meals, and it's also about approaching nutrition balance, about what we want to make more available and plan for, as opposed to tell people what not to eat. So focusing on what to add instead of focusing on what to take out. The cooking skills are often in mental health, I think, underestimated. It's not everybody that got exposed to how to cook certain food, the process that are involved into the preparation. There's certain organization that can help you with that, but in general terms, that's definitely something we need to address. How to cook vegetable and that can be tasty and enjoyable and well seasoned. And also in terms of meal logistic, how to be flexible and resilient. I think, if anything, COVID-19 taught us a lot about resilience and coping mechanism and flexibility. When it comes to meal logistic, it's a little bit the same. A lot of people will use very structured, guided, restrictive meal plan, but then they're not necessarily going to have the capacity to be flexible once that is becoming boring. So addressing that, okay, what do we do if we're missing an ingredients? What do we do if you eat out? It's not just about preparing food, but it's also about how do we react in different situations. The third point that I bring into how we connect nutrition and mental health is body intelligence. And body intelligence, in terms that I would explain to patients, would be about how do we understand and deal with external factor and internal factor that affect how we eat. I was telling you earlier about the overload of information. In a lot of ways, the way that we eat is a lot directed by external factor about knowledge. But if you think about it, nutrition is just as important in terms of biology as it would be eating food, would be as important as going to the bathroom. When we feel the need to go to the bathroom, we normally just go. You don't check your watch and be like, it's not really my time to go to the bathroom. I'm going to wait a little bit. It's not, it's not the time, unless you're busy doing something else. But that feeling of needing to go to the loo will resurface and you will probably answer it. When it comes to food, however, that messaging of hunger cues and making decision around food is often influenced by a lot of other things. And when we just focus on telling people what to do, we don't get a good understanding of what affects the way they eat. So to point out a few different points that could be looked at in that context of adding on the understanding of external and internal cues of eating, I would work with people on understanding who do they hang out with that would sometimes pressure them to eat more or certain food, or what would be their reaction when they're exposed to bigger portions, for example. How do they relate to their hunger? Some people that would have been on diet for a long time will have kind of a love-hate relationship with hunger, and the same for satiety. How do you feel like satiety and fullness? How do we manage energy during the day? And those would be more internal cues: hunger, satiety, fullness, blood sugar to a certain extent in terms of energy control, and also factors of satisfaction and taste, which in a lot of ways, when it comes to food, we focus a lot on food science for physical health purposes. But I think we forget the mental factor surrounding nutrition, whereas about we also eat to enjoy. We eat for satisfaction and taste and enjoyment. So we want to bring eating psychology and food science together a little bit more. And that's where external and internal cues, so physical cues and also knowledge, when we balance those two things together and discuss them with patients, when we take the time to do that, I think we can decrease anxiety, improve self-efficacy and awareness. And some of the tools to address internal cues are based on interoception, or a capacity of feel certain body sensation, like a heartbeat or hunger and things like that. And when we have more awareness of those body cues, we have more information to make decision, and we can also be a little bit more reflective on our routine and how we can react in different situations. The same way I was telling you before about resilience and flexibility, if we know what tends to push us around a little bit, push or pull us when it comes to food intake, then we feel a lot more at ease, we feel more in control, and we can be resilient about what is happening. Another part that is often neglected when it comes to food, or I would say maybe overused, cognitive restriction, when it comes to diet and diet mentality, food rules, right? That's something that when we start talking about with patients, there's a lot of things that come out, and sometimes we lift a big load off their shoulder. Most of you would be probably knowledgeable about the cognitive restriction cycle, or the restrict and binge cycle, the restrict and relapse cycle. So when people are told, and are often told actually, to cut carbs, to avoid fat, to decrease certain things, or to avoid buying things, not to go to the restaurant, or it's often done in a restrictive kind of way. So when we're trying to restrict, it gives a sensation of deprivation. I feel that the best example of that is saying, tell your kids that they can play with any games, but not the red truck. And then just imagine what happens after. And it's the same for food. I think it's a concept in psychology that we're pretty aware of, but I think sometimes we don't really bring that enough in the nutrition field. So you have restriction, deprivation, then is going to often lead to craving, and people are going to be somehow exposed or invited to have food. Then they might overindulge because they have this last supper mentality of this is now or never, because I need to restrict tomorrow and go back go back on the wagon. So this, when we talk to patients about cognitive restriction and how does it feel to have so many food rules, to feel restricted, and how do you react from a metabolic, like a biologic point of view, but also from a psychology point of view. And from a cognitive restriction, the more cognitive restriction, the more you're trying to restrict and control, the more we're decreasing the cognitive energy, the mental energy. And we know from research that cognitive energy is a limited resources. So you can get rid of, run out, of cognitive energy, because it's also divided throughout all the sphere in your life. Your work life, yes, eating food, but also dealing with your partner and your kids and all that. So explaining that to people could be helpful. Also, acknowledging that this cognitive energy is different for everybody and it's variable, does vary depending on the stage of life, and it can be modified as well, right? We can train people to be more resilient, and it's renewable. So we can get more, we can run out and then go back to what we were doing. That's why people kind of are on and off diets a lot. They restrict and then they fall, and then they kind of replenish their cognitive energy, and they're like, okay, I'm going to go on a next diet now. So these are the way that we talk about food. If we can avoid being in cognitive restriction, and in a certain way, I would bring us back to meal planning, then we have an opportunity to improve mental health. The last point that I want to touch on about is emotions and food. I would say the word emotional eating, but I feel that it's been really overused, especially in the context of COVID, and it's been seen as evil. And for sure, I would say that there are ways that we cope with emotion with food. And the analogy that I give to patients when it comes to trigger analysis and understanding in what context did they eat a lot of a certain food or felt guilty about eating chocolate, for example, would be, okay, something happened like isolation and coronavirus, and it threw us all off our balance, right? And some people felt like they were drowning in a lot of emotion and a lot of this, probably financial insecurity and all that. So you were kind of drowning, and you got hold of a life jacket, right? And that life jacket that is more available when you were at home tend to be food. So you hold on to your life jacket, you're kind of struggling. As a dietitian or as a health professional, nobody wants to come in and grab that life jacket and tell the person, you need to swim now. Come on, like, stop using food as a coping mechanism. You need to swim. And yet I feel that it's a lot of the messaging that people have been getting. I need to distance myself from the fridge. I need to kind of, pull away from that life jacket or that coping skills. And I think the way that we can bring mental health into the picture when it comes to food specifically is to say, well, how many other life jackets can we put around the person to help her float and to help her cope with the situation? So when it comes to food, I would look at, yes, the food that people eat, and I would address at the basis of things, okay, how is meal regularity? How are we doing in terms of the biological need for the food? And then address the psychology. Because if you're hungry all the time and you feel bad for eating certain food, and you feel out of control, it's very difficult to address. So trigger analysis, talking about food in a different way, in a compassionate, kind way, talking about what is the intention when we cope with emotion with food, and what other things can we need? Do we need support? Do we need self-care? Do we need just acknowledging how difficult the situation is? Or do we need other distraction than food? And can we brainstorm those tools and coping skills before the next stressful event or trigger happens? So I started the conversation talking about people being very much overload with information and being often told, okay, I need to lose weight. And it might feel sometimes like people are walking the desert looking for water, looking for the magical diet. But what often happens when we just tell people what to do and how much to eat and what to eat is that people will dig somewhere and find a little bit of information about a certain diet and get bored of it because it's not really, it's just a copy paste and it doesn't really match their needs. And then they'll dig somewhere else a little bit and a little bit. And so we have like a desert with a lot of holes and no water and no change. And often we can leave people a lot more struggling than we found them. So the take home today that I wanted to present with you in terms of research, concept, and strategies to bring a little bit more awareness of mental health in the nutrition field would be one about definitely motivational interview and how can we treat patient as an expert of their own life. Of course, we're expert at what we do, but they also know a lot about, how they live their life, their culture, their tradition, their preferences, and we need to value that and listen a little bit more. The second is about meal logistic and executive function. It's not enough to know. I think we need to be a lot more supportive of how we're going to get there. What tools do we have to ease the process of jumping or building the bridge between knowledge and action without insulting people's intelligence. And the third part would be about maybe getting out a little bit of our head and a little bit more into the body to balance how we make decisions with food. So both with internal cues of body intelligence and external cues, understanding what affects the way we eat. Food rules and cognitive restriction, if we can move away as much as possible from the diet mentality, I think we're going to support people's mental health a lot better. And talking about emotion and emotional triggers and emotional eating in a compassionate way and looking at different strategies that can be used to cope with emotion, maybe with food, but maybe adding a combination of other strategies around it. So in all those 5 points, the goal and what we see when you look at the research for certain of those subjects is that we have an opportunity to decrease in anxiety, weight stigma and shame and guilt that is surrounding food and body image, and also decrease the mental load. Because we want to promote autonomy, resilience, flexibility. If we move away from weight stigma, we move towards social justice because we want everybody to have the same great level of care. And we can also promote purpose, because in a lot of ways when I help people to promote mental health and to sort out nutrition, they can think about food a little less or the right amount so that they can be purposeful with their time to do something else that they love to do. I talk about food all day, but I don't think that people should feel overwhelmed and concerned about what they eat all day. If you have any questions or if you want to connect to push the conversation further about those concepts or strategies, please feel free to reach out and contact me by email or by phone. I would be happy to get in touch with any of the presenters today or participants that are interested in promoting mental health. I think it's much needed, and I'm happy to be part of the conversation. I'm going to leave you also a few resources, and I wish you a beautiful day.
For that really informative talk, and I think we can all agree with the importance of nutrition and how it can support mental and physical health. Now on to our next speaker, whose talk is titled Weight Stigma in the Medical Profession. I'd like to introduce Karina Khazin. I hope I've pronounced that correctly. Karina is a clinical psychologist. She has a master's degree in clinical and psychopathological psychology, a postgraduate degree in clinical and psychopathological psychology from the University of Sorbonne, and a diploma in profound studies in clinical psychopathology as well. She has joined the American Center of Psychiatry and Neurology in Dubai in 2011, and as an eating and weight disorder specialist. She has not only set up, but is also the director of a specialized multidisciplinary multidisciplinary outpatient eating and weight disorders program, which are based on evidence-based models. She's the vice president of the non-governmental organization MEDA, which stands for the Middle East Eating Disorders Association, which is a chapter for the Middle East of the Academy of Eating Disorders, AED. She oversees and runs all the association's daily operations dedicated to raising awareness, supporting sufferers, and training the general public and professionals on the subject of eating and weight disorders.
Hello, everyone. Thank you for inviting me to present at this very important conference. I have chosen to discuss today weight stigma in the medical profession because I believe it's a very important topic that is unfortunately not frequently addressed. I have nothing to disclose other than I am thin privileged. That means I have never experienced life firsthand in a bigger body, but I have been working with patients in bigger bodies for a very long time. To start my talk, I would like to draw your attention on the number of hours medical doctors receive on eating disorders and obesity or weight. I'm going to try not to use the word obesity because it's a word that I don't like, but sometimes I will have to refer to it. So basically, if we look at the numbers of hours that medical doctors receive, it's almost nothing. And they are in the first line when they deal with eating disorders or weight management. Before seeing any specialist, a person who suffers from an eating disorder will see his GP. And if someone wants to lose weight, the first person he will see is going to be a GP too. And unfortunately, the GPs that have received regular medical education don't have the tools and the knowledge to deal with this population. And this is why they cause serious harm. There is no bad intentions here, I am sure, but the reality is that there is harm being caused because of lack of training and because of lack of awareness and because of lack of knowledge. I myself, when I started working in this field, the field of eating disorders and weight management, even though I reject really very, very strongly diet culture, and I am really passionate about weight inclusive care, I did do some harm because I didn't know any better. So there is no accusations there. I'm the first one who did harm, but since then I have learned, and hopefully I'm doing less harm today. So what is stigma? Stigma is the attitude that someone is unacceptable or not good enough because of a difference. And unfortunately, stigmatization leads to self-stigma. And people who are stigmatized develop very negative beliefs about themselves. So it has an impact on self-esteem. Weight stigma, what is weight stigma? Weight stigma, we can call it weight stigma, weight bias, weight discrimination. It's a discrimination, so it's a judgment or a stereotype that we have based only on a person's size. And people who stigmatize people in bigger bodies are usually fat phobic. So they have a problem with people in larger bodies. Unfortunately, weight stigma does harm. Again, going back to the basis of weight stigma is always used in good intentions. So people who stigmatize people in bigger bodies have the intentions to help them. They want to motivate them to change their behaviors. And they think that by stigmatizing them or shaming them, the behavior will be changed. Unfortunately, it's exactly the opposite that happens. There is a severe impact of weight stigma in general. So because of weight stigma, there is an impairment on the quality of medical care, and this has a direct effect on mortality. People who have been stigmatized because of their body weight experience depression, body dissatisfaction, low self-esteem. They are at higher risk of binge eating. They are at higher risk of having an eating disorder, specifically the binge eating disorder. And in reality, weight stigma, as I said previously, not only doesn't help if we're trying to tackle the issue of obesity, but on the contrary, it is believed that it is obesogenic. So people do the opposite reaction, and they start to they want to stop losing weight, and they indulge in food for comfort even more. There is an inner rebel in all of us, and I guess it gets triggered. Who stigmatizes usually? The first one are family members, unfortunately, and the second ones are physicians. So physicians, in the best intentions they have to do good and to help their patients, they are actually doing harm. They're using weight stigma, which is doing harm. I believe weight stigmatization is a social injustice and a public health issue. And I'm going to discuss specifically the public health issue. First of all, let's make something very clear. Health cannot be ascertained by appearance. You cannot know if someone is healthy just by looking at this person. This person might appear very healthy and in reality be very unhealthy. So for example, a lot of toned, muscular people who suffer from anorexia nervosa are maintaining a healthy body weight by starving, and they're extremely unhealthy. Whereas you might have someone in a bigger body but who never dieted and who maintained a bigger, their genetic set weight throughout without dieting, etc., will be much healthier than such a person, much, much healthier. But the reality is that we are being fed that you can judge a person's health based on their appearance. We have a big dieting industry that makes us believe that the bigger you are, the unhealthier you are. And to achieve health, you must diet, which is exactly the opposite, because if you want to be unhealthy, the best thing to do is to diet, basically. In our society, fat has become a moral issue. So not only it is associated with being unhealthy, but it is also associated with some kind of moral failure. People who are in bigger bodies are perceived as being failures, not having enough willpower, not having enough control over their food, being weak. And it's really terrible because our weight is genetically predetermined. In reality, we don't blame people for developing any disorder, I hope, and definitely not for developing cancer. But when someone has diabetes, high blood pressure, or other number of health issues that are related to weight, because yes, there are some people that have medical complications that come from being in a higher weight, it's a reality as well. But not everyone in a bigger body will have those medical complications, and that's the confusion. But anyhow, the perception from the medical community is that, or from anyone in general, is that the cause of the excess weight is a lack of morals or some kind of problems in their personality, when in reality, as I said, and I repeat, weight is genetically predetermined. So, do we use the BMI? Only for extremes, really. The BMI was never developed to be a measure of health. Unfortunately, it is widely used by most people and most physicians to ascertain health. So basically, it was developed on predominantly European men. So it's not fit to be used on women. It is not fit to be used on people of color. It is not fit to be used on other than European men, basically. And even then, there's a big question mark, because it doesn't take the body composition into account. It's just a simple, very simple, weight to height ratio. So basically, some people have high BMIs because they're very muscular. Are they going to be unhealthy? Not necessarily. It doesn't take the racial differences into account. We know that people of color carry more muscle and are usually genetically in bigger bodies. That doesn't mean that they're unhealthy. And most importantly, it doesn't take genetic predisposition into account. So it's very important when we meet a person in a bigger body as a medical professional or as a clinical psychologist, and if this is what they're bringing on the table, of course, we should not open the topic if the person is not bringing it on the table, to talk a bit about the family, how are their parents, siblings, and you'll see that most of them are also in bigger bodies, so there is a big genetic component. Unfortunately, the medical community has adapted it to measure health. It is very dangerous. And the data shows that really the BMI, when we look at mortality and BMI, the BMI was of limited importance. What really makes a big difference in terms of mortality and decreasing the mortality risk or the early mortality risk is physical activity. And when I say activity, I don't mean necessarily going to the gym and having an exercise regimen, but people who are more active, have a bigger number of step counts, etc., are usually have a less of a risk of mortality. And in fact, this very important study on the veterans, on 12,000 middle-aged men, observed that the healthiest were the obese men, so higher BMI with a high exercise capacity. So basically, if you're just a bit active, even if you don't change your body weight, it is likely to resolve all or a big part of the metabolic syndrome that comes with higher weight if you have metabolic syndrome, and it will increase longevity and decrease the risk of early mortality just by being physically active. So what's the reality? The reality is the weight is not the problem. The weight is the approach that the medical community has with people in bigger bodies. Because they are most of the time stigmatized, people in bigger bodies don't go to see the doctor anymore. And this is why they don't get treated when they need to get treated. So this is the biggest problem. And I've heard it thousands of times. Every time I see for a consultation a patient in a bigger body and I ask, when was the last time you had a medical checkup? It's 10, 15, 20 years ago. So there's a real avoidance of that. Usually, so I said that it's a public health problem. Weight stigma is a public health problem because the direct effect of weight stigma is that people in bigger bodies are going to avoid seeing the doctor, hence will not receive medical care. So people are afraid to go see the doctor because they have been judged most of the time, sometimes shamed, sometimes bullied. And they don't want to expose themselves to such an experience, so they avoid going to the doctor. There has been a lot that has been written on the topic, and if you just Google it, you'll see tons of testimonials that are really relevant. So why do people in bigger bodies avoid going to the doctor? First of all, there's the doctor's attitude. So most doctors will prescribe weight loss for any other problem that might not be related at all. The offices usually are not friendly, so people in bigger bodies are not comfortable sitting down. The examination gowns are too small. The blood pressure cuffs don't fit larger bodies. The furniture of the office is not comfortable. Sometimes they can't sit in a regular chair. There are BMIs charts everywhere that highlight the dangers of being in a bigger body, etc. So that's a funny cartoon, but it gives us an idea of the reality. So doctor, I've been impaled, but what does the doctors say? Maybe you should lose some weight, as if both were related. So of course it's a cartoon, and of course it doesn't happen, but a lot of the time you would be surprised how much weight loss is prescribed for related medical conditions. So weight loss is prescribed, but weight loss doesn't work. Diets don't work. And this is a fact that has been proven by extensive studies. Also, you could Google it, the efficacy of diets, and you'll see, that not only diets don't work, but diets in the long term increase the risk of being overweight, because your body is primitive. So when you're on a diet, it doesn't know that you're on a diet. It thinks you're on starvation, and it's designed to protect you against starvation. So it will lower your metabolism, make you burn less, and give you very strong obsessions over food, which leads to overeating after a diet with a lowered metabolism, which leads to a higher body weight. So again, I'm sure most doctors have the best intentions, but diets and prescribing weight loss, specifically strict dieting, is not only completely counterindicated, it is harmful, and it will promote excess weight in the long term. But the reality is that there's a multi-billion-dollar machine that promises, solving all the weight issues and bringing happiness and fulfillment if you lose weight. So there is an industry that is making a lot of money from our body's insecurities, and that is promising you the resolution of all your problems if you lose weight, your medical problems or your psychosocial problems. So this is an example I've chosen just to show you how, also this weight bias happens in surgical care and can be extremely damaging. So typically, so let's take a look at the knee replacement surgery. So typically patients are told to lose weight, otherwise they cannot have the surgery because doctors are concerned, surgeons are concerned of the medical complications of surgery in a bigger body. So what happens? Desperate patient is going to diet to be able to be allowed surgery. So diet means the patient will get to the surgery. He might have lost weight, but he'll be malnourished. He'll be tired. His immune system will be down because of the diet, etc. And a study noted that presenting to surgery malnourished from taking on too few calories and breaking down body tissue, which is basically losing weight, may itself cause poor wound healing and infection, which are initially the first reasons why surgeons recommend being in losing weight before surgery. So it does exactly the opposite. And if you look at data, weight loss before knee surgery is not evidence-based to improve outcomes. Another problem that we have, so as we said, patients in bigger bodies have bad experiences with doctors, so it leads to them being sometimes shamed, bullied, and internalizing this negative experience and developing self-stigma and having self-esteem problems. It leads to depression, to binge eating, etc. So eating disorders as well. It leads to doctors, to patients avoiding doctors and hence not treating their medical conditions, even those which are not related to body weight, because they're so afraid of the judgment and because the whole experience of seeing a doctor in a non-weight inclusive model is stressful. But it will also lead to surgical problems when weight loss is recommended before. It leads to people recommending diets, which in reality is going to make the patient gain more weight in the long term. But it also this weight stigma leads to missing out on eating disorder. Because we think that to suffer from, we think the community, society in general thinks that to suffer from an eating disorder, you must be in a very specific body. And this has been unfortunately perpetuated by the media, etc. So automatically, when someone is in a bigger body, no medical doctor or dietitian or psychologist will check for an active eating disorder. Some of them are anorexic. There is something called atypical anorexia, and it affects 3% of the population. So people in bigger bodies, and I have seen many patients that came to me after being denied care all over, not only in the UAE but in the world, because they were in healthy or even overweight bodies, so they could not have an eating disorder, or anyhow they could not have anorexia. So those people were basically starving on 100 calories a day just to maintain this either normal BMI, because genetically they are in heavier bodies, and in order to be a normal BMI they have to starve and to stay starved, which means they are fully anorexics, or they are still overweight because no matter how much they were able to starve, they did not, because you have a genetic set weight and the body defends it, they were not able to reach normal BMI, and those people are going to be recommended weight loss diets when in reality they're already starving to maintain this heavier BMI. So atypical anorexia is a big problem. So I would very, very strongly suggest to check, that there's something called the suppressed weight. So you basically ask your patient, what was your weight most of your life? And if your patient was 20 or 30 kilos heavier most of his life, he's most probably now starving to maintain a normal body weight. And this is someone who probably has a case of atypical anorexia nervosa. Again, you do not have to be emaciated to be very sick from an eating disorder. So basically, you don't have to even be losing a lot of weight to be starving, because your body is very good at basically preserving and defending your genetic set weight. So this woman, this lady, Jackie Valdez, she's an atypical anorexic. So this was her body after starving and purging and taking laxatives, etc. So full-blown bulimia nervosa. And she was denied care in general, because everyone was complimenting her and telling her that she was doing a great job and that she lost a lot of weight and now she was healthy. In reality, at that point in her life, the picture that you're seeing in front of you, she was extremely unhealthy. She had bradycardia, arrhythmia, she was really in a very, very bad shape, but everyone was complimenting her on her weight loss and on her healthy BMI. This is her genetic set weight. So this is where she can be healthy. So when you are below your genetic set weight, your body and your brain is unlikely to function normally. And in order to reach a lower weight, you must have used extremely, extremely drastic measures, which mean usually eating disorders. So it is important as doctors to acknowledge the societal pressures and to understand that there's a huge, industry that promotes weight loss diets. And we need to understand that these are tempting, but they are extremely misleading. And as a doctor, it would be great if we could suggest weight neutral plans that focus on eating disorder recovery, so normalizing the relationship with food, maybe improving the eating habits, being more active, behavioral change, not body change. Because we will see that just being able to change slightly and improve the quality of the food and increase slightly the level of physical activity are sometimes enough to reverse most of the medical complications when present in people in bigger bodies. Not everyone, again, has a metabolic syndrome and not everyone has medical complications. But if they do have, the solution is not necessarily weight loss. The solution can be normalizing eating habits, stop binge eating if binge eating is present. Usually it's present in 50% of the cases. Being more active, and this should be enough. There is a movement called Health at Every Size, and this movement has published multiple studies proving my earlier point that you do not have to lose weight to improve if you have medical complications. Just improving the quality of your food and being more active is more than enough. And this relieves a lot of patients from the detrimental psychological effects of diets and physical effects of diets, because everyone that diets ends up being depressed, tired, has no energy, and at the end, they are going to regain the weight. So it's really a lost battle that is detrimental in terms of self-esteem, in terms of body acceptance, and it is impairing on their daily life. So if we can avoid that and focus on a weight neutral plan where we're not discussing body weight, but when we're targeting more behaviors and also treatment of mental health issues that might have arisen because of the weight stigma and the constant dieting, then this is where we're making a difference. What is weight inclusive medical care? It is not checking or discussing a patient's weight unless it's someone who is on nutritional rehabilitation and should be gaining weight, and you are going to basically monitor the weight progress. Not perpetuating diet culture on patients. Do not prescribe weight loss diets that do not work. And if your patient develops any of the medical issues associated with higher weight, refer to a weight-inclusive internist for treatment, or work with your patient to change their eating habits and their level of physical activity to reverse those medical complications. I believe very strongly that weight-inclusive care is the right approach, psychologically, nutritionally, medically, and ethically. Otherwise, we are doing harm. And as a medical doctor, which I'm not, but you are, and some of you are, it is about first do no harm. So if you look at the study that Jennifer Gaudiani, she's really the lead, she's a medical doctor specialized in eating disorders and weight-inclusive care. And in her own practice, she did the study comparing binge eating patients who received weight-inclusive medical care to binge eaters who did not receive weight-inclusive medical care, and the outcomes were crystal clear. So the patients who did receive weight-inclusive care had a better, at the end of treatment, had a better quality of life, more energy, a better sleep, ate more intuitively, had less eating disorder symptoms, experienced less weight stigma, and had improved medical outcomes, again, without having lost any weight. So the take-home message is, let us not contribute to fat shaming and weight stigma, and let us change our approach towards people in bigger bodies, and so that people are less afraid to go seek medical help when they need, and so that we are not responsible for people in bigger bodies developing mental health problems because of the weight stigma. So this is one of my patients. She's a Lebanese woman. She was never, she's 45 years old, BMI 35, and she was never successful at losing weight. And she doesn't go see doctors because every time she goes see a doctor, the answer to all her problems, whether they are of any kind, is you must lose weight. And what does she do after? She goes and she buys herself something nice to eat to comfort herself because she's distressed by the appointment. So this is a direct result between weight stigma in the medical office and overeating or binge eating as a response. And this shows you briefly the harm that is being caused. Thank you very much. I hope you have enjoyed my talk. I know it's a bit controversial, but I believe it is the right approach, and when you start practicing it, you will see the big effect it has on the patients you treat, because at the end of the day, we're all here to help our patients who come and see us. Thank you so much. Thank you for listening, and see you soon.
Our live, Dr. Bing.
Thank you, Kareem, for that really informative presentation on stigma and weight. And now I'd like to introduce the next speakers on their title, their lecture, The Maudsley Health Approach to Eating Disorders, Risk Assessment and Treatment. I'll introducing two speakers. So firstly, Dr. Victoria Mountford from Maudsley in Abu Dhabi. She has a doctorate in clinical psychology and joined Maudsley Health from the prestigious SLAM Trust in London Eating Disorder Service. She combines her clinical work with research and teaching, and has over 20 years of experience of working with individuals with eating disorders and body image concerns and their families. She is a VAP accredited practitioner, supervisor, and trainer. She was part of the founding team who developed FREED, which is the first early intervention eating disorder service in London, in the United Kingdom. And she completed her bachelor's in psychology at Reading University and her doctorate at UCL. Our second speaker is Dr. Tazim Danji, who obtained her specialist training at the renowned Tavistock and Portman NHS Foundation Trust in London. Her training and clinical experiences have enabled her to adopt both a psychiatric and psychodynamic approach to the assessment and management of patients, and she continues to hold membership with the Royal College of Psychiatrists. She went on to, as a consultant in a multidisciplinary eating disorder service within the Royal Free in London, which included providing outpatient care, pediatric and psychiatric inpatient support, as well as working with day patients who required intensive eating disorder support. And she has also worked closely with medical colleagues to ensure the physical safety of patients and developed pathways to support the management of eating disorders in emergency and pediatric care. And I'm very lucky that they're both colleagues of mine in Abu Dhabi.
Hello everyone, I'm Dr. Tazeen Danji and I'm a consultant child and adolescent psychiatrist. I've just recently joined Maudsley Health. However, prior to that, I was working in an eating disorder service in North London, and I'll just hand over to my colleague to introduce this.
Hi, I'm Dr. Vicky Mountford. I'm a consultant clinical psychologist. I've worked with people with eating disorder for 20 years. And that includes developing and working in outpatient, partial hospitalization and inpatient settings. I'm also active in research and teaching, and my particular research interests are improving psychological treatments for people with eating disorders and improving the understanding and the treatment of body image.
Okay, so today's session, we're going to be talking about Maudsley Health's approach to eating disorders, and particularly we'll be thinking about the different impacts that eating disorders have on a patient. So I'll be starting with thinking about why eating disorders are important, and then I'll be covering the physical aspects of having an eating disorder. And then Victoria will move on to the psychological aspects, thinking about the impact of COVID and culture. And then lastly, to discuss what we offer here at Maudsley Health. So why are eating disorders important? Well, they affect both physical and psychological health. And according to recent statistics, we know that eating disorders affects at least 9% of the population worldwide. It has the highest mortality of all psychiatric disorders, and about 26% of people with eating disorders attempt suicide. So I've included some statistics from BEAT, which is the UK eating disorder charity, in terms of prevalence and the female to male ratios. But something I wanted to highlight is that the standardized mortality ratio for anorexia is higher than that of asthma and type 1 diabetes. So it's an extremely important disorder to be thinking about, particularly as those with eating disorders have a higher mortality rate. So those with anorexia have a 5 times higher mortality rate than the general population. This is quite a nice slide as it shows the different comorbidities that may be associated with eating disorders. And what's important to think about is whether these disorders are pre-existing or whether they're as a result of the starvation, in particular in anorexia nervosa. And so often you'll be trying to take a really good clinical history to work out whether there's an underlying comorbidity to treat or whether you would expect there to be some improvement in the symptoms following weight restoration. So what are the consequences and impact of having an eating disorder? Well, these are huge. There's an impact on family and social life, impact on relationships of the patient, and also education and work. I'm mainly going to be thinking about the physical aspects, and as I said, Victoria will cover some of the psychological impacts of having an eating disorder. So as you can see here, the brain is continuing to develop well into adolescence and early adulthood, and the main parts of the brain that are developing later on in life involve those areas that are trying to regulate emotion or involved in arousal. And so it's really important that if during this time there is an insult such as starvation or poor nutrition, that actually we're thinking about the effects that that can have on development of these parts of the brain, and also an important thing to consider in terms of treatment. What you can see on the right hand side is an MRI scan, and this is of a young person with anorexia nervosa, reduction of brain volume. So in terms of the physical impact of having an eating disorder, this slide shows both that for bulimia nervosa and anorexia nervosa. I won't go into all of the different systems. However, it's just important to know that eating disorders affect every system in the body. And there can be some long-term complications of having an eating disorder. So in some patients, amenorrhea may later on in life cause difficulties with osteoporosis. And also in some patients, we may see an effect on growth. Bulimia nervosa itself can have some difficulties in terms of the physical complications of vomiting, but also the electrolyte imbalance, which can then cause secondary complications such as heart arrhythmias. So it's really, really important to be able to physically assess a patient with an eating disorder and to be able to manage these potential complications. So in order to think about the risk assessment, I've split this up into two steps. The first is looking at the physical risk assessment, and then the second is looking at refeeding. So the marzipan guidelines are the guidelines that were developed by a working group of physicians, psychiatrists, dietitians, and general practitioners. And it basically looks at different parameters to give us an idea of how to assess the physical risk in someone with an eating disorder. So the link there is a link for the adult marzipan guidelines. And I've actually, in the next slide, I'll be able to show you the summary for the junior marzipan guidelines. What's really important is that we're not working alone with these patients. So I think it's important all the way through to be liaising with our medical colleagues and our dietitians. So here, as you can see, this is a summary of the junior marzipan guidelines. And what you can see here is they use a traffic light system to look at risk. So I won't go through this in detail, but the parameters that are being looked at are percentage weight for height, any sort of hemodynamic compromise, line standing blood pressure, heart rate, ECG abnormalities. We're also looking at things like temperature, any biochemical abnormalities, whether there's any increased risk as a result of things like vomiting or laxative use, and also things like high levels of exercise. So depending on the different parameters, what you can then do is try and ascertain a patient's risk level. So if they have a parameter in the red column, then they're at high risk and you might be considering hospital admission. And again, you'd be wanting to consider sort of have a conversation with medical colleagues. For those who are at low risk or moderate risk, and there's a feeling that they can be managed as outpatients, then usually these patients will be managed at home, but with a multidisciplinary team around them. The thing to say here is that you also want to try and assess things like what is the patient's family or their partner's capacity to be able to help in treatment if they're being managed at home, and also whether there's any psychiatric risk, because that may affect whether somebody is being admitted or not. So this slide just tells you a little bit about refeeding syndrome. So refeeding syndrome, it's a serious potential complication of commencing refeeding in somebody who's been starved. And it's as a result of the fatal shifts in fluids and electrolytes, which is characterized by low phosphate levels. So it's really important to be checking for somebody's refeeding risk, particularly because it can have such serious complications, which may include things like confusion, entering a coma, or respiratory and cardiac failure. And so the next slide shows, again in a traffic light system, some of the high risk factors that might mean that a patient is at risk of refeeding syndrome. So again, we're looking at somebody who has a percentage weight for height that is lower than 70%, somebody who is eating very little or has had very little to eat in the last week, whether they already have low biochemical markers, particularly phosphate, or a low white cell count, and also if there are any of those risky behaviours associated with the eating disorder. So again, you're assessing their risk, and then you need to be thinking again with your colleagues about whether this patient needs to be admitted into hospital for refeeding, or whether they can be refed at home. Some of the important baseline investigations such as bloods and ECGs or physical examinations need to be done, and these patients may need daily refeeding bloods. So it's important that even if they are being managed at home, that they do continue to have these investigations. Some of them may be on prophylactic medication, and they'll be following a refeeding meal plan, which means that the calorie intake is going up very slowly. And one thing to note is that if any of their biochemical markers are abnormal, that actually they're normalized prior to increasing that calorie intake. And finally, I just wanted to say, you know, one of the things that is really important, again, in eating disorders is to think about the other physical complications which may happen. This is just a list of complications that I've seen myself or that colleagues of mine have seen. But again, it's not an exhaustive list. And I think it's really important to also consider when a patient is coming to you for an eating disorder, where there could be an organic disorder in the background. So again, we've had a patient in the past who has come with weight loss and vomiting. You know, everything has kind of pointed to an eating disorder, but actually in the end, the patient had a brain tumor. And so it's really important to think about these other disorders surrounding an eating disorder. Okay, I'll now hand over to my colleague, Victoria.
Thank you. So it's also really important to consider the impact on psychosocial functioning. It's essential to monitor and assess psychiatric risk of these patients. As Tazeen said, they are at a high level of attempted suicide. What's also really important to consider is that psychological recovery often takes longer than physical recovery. And it's important to share that with both patients and their families, as sometimes people can worry that once they restore to a healthy weight, all the help is suddenly going to disappear. Individuals with eating disorder might experience self-harm and an increase in suicidal thoughts, alongside increased anxiety and depression. And we also know that there might be episodes of emotional distress, for example, mood swings, irritability, and anger. People with eating disorders may also experience low self-esteem, and alongside this, some very distressing emotions such as shame, disgust, and guilt. However, the individual's cognitive abilities will also be affected. So, for example, they may have poor concentration and find making judgments and decision-making harder than usual. What also is a real narrowing of interests. So things that the person used to enjoy, they stop enjoying anymore, they lose interest in. And often those interests become really focused down on food-related things like recipes or cooking or fitness. Particularly when an individual is in starvation mode, we see that their thinking becomes much more obsessional and rigid. And part of this is seen with the increased preoccupation with food that people experience. So, for example, we will find that some individuals will say that they spend a lot of time worrying about what they've just eaten, what they're about to eat, and so on. And this can really take over their lives. I think, however, one of the most important things to remember when working with individuals with eating disorders is how lonely they often are. Having an eating disorder really puts you in your own bubble and makes it hard for you to connect with peers and family in the way that you used to. So often our people with eating disorders experience significant social withdrawal. So let's think about eating disorders here in the UAE. The research here does have limitations, and a large amount of it is focused on self-report questionnaires that look at eating attitudes rather than eating disorder diagnoses. However, what we know is that among adolescent females, one study found that approximately 23% scored above the cutoff on a measure of disordered eating attitudes. And when they looked at these individuals in more detail with a clinical interview, they found that 2% were meeting criteria for an eating disorder. It's really important that we don't forget males, however. And another study showed that up to half of adolescent males scored above the cutoff on a measure of disordered eating attitudes. So overall, this suggests that rates may be equal or above those seen in Western populations. So why have we seen this increase in the UAE? We know that there has been rapid socioeconomic and social cultural change. And often with increased globalization and increased industrialization, we do see an increase in eating disorders. This may be because of an increased focus on the thin ideal, some of the changing work and educational roles for women in the UAE, and new behaviour patterns, where we know that there now is ready availability and lifestyles may be fairly sedentary. However, I think one of the challenges may be stigma surrounding mental health problems and a tendency to keep discussion about mental health problems within the family rather than seeking outside support. What we also know is that there is a lack of that available support, including specialised eating disorder services. It's also important to remember that treatments were largely developed in Western populations, as were assessment materials and so on. So we need to think about how these treatments can be best adapted for the population here so that we are treating people in the most effective way. As with any culture, there are patterns and traditions and norms around eating. In the UAE, it's very important to share food and to be seen as generous. However, it is also seen as offensive not to accept food. And this can create some challenges for people who are trying to manage their eating. We also know that during Ramadan, the practice of fasting and then breaking that fast at iftar can present challenges for people with eating disorders. And of course, what has been a challenge for all of us has been COVID-19 and the subsequent lockdown. And when I talk to my colleagues around the world, we're all reporting an increase of cases of eating disorder symptoms. So I think there are some very good reasons why that might be the case. So that everybody experienced reduced ability to exercise and often a reduction in our daily structure. So we had to spend lots of time at home and we couldn't do the things that we normally did. For young people, this was especially apparent in the form of online schooling. And unfortunately for young people, online schooling also meant that they were beginning to see themselves on camera all day, every day, and also worrying what their peers and their teacher may also be thinking about them. For some people, there's been reduced access to foods or brands that have been seen as safe or known, and that's created increased anxiety. With the COVID, we also know that anxiety in general has increased. And again, some people have experienced contamination fears, which may have made it more difficult for them to eat in the way that they did before. And I think what's also been a challenge is some of the unhelpful media messages about making sure you don't put on that quarantine stone. And certainly among some of the young people that I've worked with, there has been a sense that during lockdown, it's important to do your home workouts. So quite often young people have started increasing their exercise whilst beginning to reduce what they're eating. So this lack of role and the need for control that we often see in people with eating disorders has created exactly the right conditions for eating disorders to flourish. However, I think what has been really positive to come out of this has been the development of new ways of working. Namely through video calls. And I've been involved in developing some of the guidelines and tips around this kind of working with both the BABCP in the UK and also this article with international colleagues, which is in the International Journal of Eating Disorders. And I think from my own experience and talking to colleagues, we are finding that we can make this as effective as face-to-face treatment, particularly in adults. And one of the things I would add is that that opens up some real exciting opportunities in the UAE to ensure that everybody in the UAE, no matter where they live, can access high quality eating disorder care. So I'll tell you a little bit about our team. We're comprised of psychiatrists and psychologists, and also speech and language therapists and OTs. And we also work with dietitians. Now, a multidisciplinary team disorders is seen as the gold standard. It enables us to provide best care. And what does it look like if you come to our clinic? So again, the gold standard is a 2 hours joint assessment interview with a psychologist and a psychiatrist, if it's an adult patient, with them and their partner if they wish. And if it's a younger patient, it will be the child plus the parents. So in that, we'll take a kind of a detailed history of what's been going on, but also review the physical assessment and look at those baseline investigations. At part of the end of that assessment, we'll discuss what the plan is for the way forward. And it's really important to state that treatment starts at that first appointment. So it's really important while motivation is high, that we get people going away and implementing changes straight away. Now, all the treatment that we offer is evidence-based, and it's recommended by NICE, the UK Institute for Health and Care Excellence. And treatment will depend on client and the family needs. For younger children, we tend to use a family-based intervention, as that has been shown to be most effective. And in adults or older adolescents, we might use cognitive behavior therapy for eating disorder, which is a treatment that's been specially targeted for people with eating disorders. And you can see the book at the top is the guide that I co-authored with some of my colleagues, which is the manual on how to deliver CBT ED, alongside Chris Fairbairn's manual as well. And we also use Maudsley model anorexia nervosa treatment for adults, or MANTRA, which was developed at the Maudsley Hospital in the UK. And again, I was involved on working on some of those research trials for that. And that's really been developed by Ulrika Schmidt and Janet Treasure, who are well known within the eating disorder field. And this is a broad outline of the stages of treatment. Each part may look slightly different depending upon the presentation and whether it's a child or an adult, how old the child is, and how much the family is involved. We will always start with physical stabilization. So this might require medical support and also psychoeducation, so we can help debunk some of the myths around eating disorders and educate people around the risks of behaviors such as purging. If the individual is underweight, we need to focus on weight restoration. But for all individuals, nutritional support is important. And we know that regular eating is one of the key factors for recovery. Psychological recovery is also important. So exploring the issues that may have led to the development and the maintenance of the eating disorder. And this will be individual therapy and/or family-based interventions. We know that people with eating disorders are often at high risk of relapse, so we always include a focus on relapse prevention at the end of treatment, and family support where appropriate. And throughout this, these stages of treatment, the individual will be seeing our multidisciplinary team of clinicians. And I just wanted to say a little bit about involving families, because this is so important. Families can feel blamed or judged when their loved one develops an eating disorder. And there are also significant challenges of living or caring for a person with an eating disorder that can lead to accommodating or enabling the eating disorder. For example, ignoring weight loss, buying binge foods, locking the kitchen or bathroom. So it's really important to engage, support, and educate the family to ensure best outcomes. And of course, prognosis is really important. We know that people get a better prognosis if they start early and if they make early treatment gains. In anorexia, this is early weight gain, and in purging disorders, this is the cessation of vomiting. People also do well if they have good social functioning prior to illness, emotionally supportive relationships, high motivation for change, strong therapeutic alliance, and particularly for younger people, an engaged, motivated, and consistent parental or care assistant. We'd like to thank you very much for listening to us today. It's been a delight to be part of this conference. Here are some resources that we recommend in working with people with eating disorders. You may wish to take a screenshot now. We would just like to say thank you very much for your time, and we look forward to seeing you at the panel debate shortly.
Thank you.
Thank you. Thanks everyone for that amazing presentation, Victoria and Tazim. I think, unfortunately, we don't have a panel discussion as such, but I will just briefly summarize some of the pertinent points from all of our three presentations. So first, I'd like to thank Jean Bedard, who spoke mainly about the link between nutrition, physical and mental health. And she's doing some amazing work in basically using motivational interviewing and basically thinking about a more personalized approach for patients in mental health and physical health as well, and also just really hammering home the point that it should be we should be empowering people to take control of their nutrition and to do their own research and do what works for them. And I think Corinne also raised some really important points about how, as health professionals, sometimes we can be part of the problem and not the solution when she spoke about stigma. So I think I definitely can, especially the example she gave of knee surgery. I think a lot of us have relatives or people who, when we use BMI and things that aren't really as physicians, we should be thinking more about the person in front of us and not being a barrier to them actually accessing healthcare. So I think that was really, really good presentation, and I think that's something that we should all bear in mind, whatsoever our specialties may be. And then finally, coming to Dr. Victoria and Tazeen, who spoke very candidly about the physical impact of eating disorders as well as the psychosocial impact, and the fact that in 2020 it still does have the highest mortality of all psychiatric disorders. And I think especially given the rise of social media and people's obsession with aesthetics has taken on a different role, I think we really need to bear all of these things in mind, and also cultural influences. So I think as much as in the past people would consider eating disorders as more of a Western disease, I think we know that that doesn't hold true anymore. I think is as big a problem here in the Middle East as it is in the West. So thanks to everyone for attending today, and to all of our renowned and brilliant speakers for talking about a very important topic. Thank you, and good evening, and enjoy the rest of the conference.